seated. Mr. Ottaway.
Good morning, Your Honor.
Good morning.
We have a bit of housekeeping we need to clean up, which is our cross-examination of Christopher Room.
Yes.
You remember that we had agreed to let the plaintiff play portion of his deposition in their case. They agreed that we could call him in our case to cross-examine him, but we have worked out the deposition designations with them. It's about 3 minutes, and we'd like to go ahead and get that in the record now. You will hear reference in the cross-examination to an exhibit S1. That is actually what you have as S4734, known as the abatement plan, state's abatement plan. So if you hear reference to S1, that's what it's about.
Okay.
Can you say your name for the record?
Yes, this is Christopher Room.
You indicate that the scope of your work is limited to providing what you call an objective and independent analysis of the cost to the state of Oklahoma of the measures proposed to abate the opioid crisis, right?
Yes.
And you've not analyzed the potential effectiveness of any of those measures, correct?
Correct.
You've not analyzed the reasons why any of those measures might be needed, correct?
Correct.
You have not evaluated the extent to which the programs or services that make up the costs calculated in S1, S or S1 are already being provided in Oklahoma, whether by the state or others, correct?
Correct.
You're not offering opinions as to the appropriate mix of programs or measures, if any, that might be required to abate what you refer to as the opioid crisis, correct?
Correct.
You're not offering opinions on the causes of what you refer to in your report as the opioid crisis, correct?
Correct.
And you've not made any effort to tie a need for any of the costs to any particular actions, conduct, or source, correct?
Correct.
Okay, and those programs and services are directed to things like treatment of addiction, establishing a helpline, not to, say, stopping Janssen Pharmaceuticals from engaging in the allegedly unlawful conduct that is described in the state's petition, correct?
Well, I won't be testifying about what the purpose of these programs or services was, but to the best of my understanding, that seems to be correct.
Okay. Do you know what opioid medications Janssen manufactures?
I don't know.
All right.
Relatively painless.
Thank you. Where was that yesterday?
The defense would call Dr. Terrell Phillips as its next witness.
Okay. Doctor, please raise your right hand. Do you solemnly swear to tell the truth, the whole truth, and nothing but the truth?
I do.
Thank you. Please be seated.
Make yourself as comfortable there, doctor, as is humanly possible in that spot. And please turn and tell Angie and Judge Bachman what your name is and how to spell it, please.
Terrell Phillips, Terrell Phillips.
What do you do for a living?
I'm an anesthesiologist and practice pain management.
So you are a medical doctor.
Yes.
Now you say anesthesiologist and pain management doctor. Can you please briefly tell Judge Bachman what that means?
Anesthesiology is the practice of anesthesia and making the patient ready for surgery, as well as interventional techniques to help with chronic pain, just pain procedures usually. And then pain management is the treatment of pain, whether acute or chronic, by multiple modalities and disciplines.
What do you spend most of your time on now, Dr. Phillips?
Today I exclusively practice pain management.
How did you get from anesthesiology into pain management?
When I finished my residency in 1985, my goal was just to go out and practice anesthesia. After starting that, various orthopedic surgeons or spine surgeons asked me to do spinal injections for their patients that was having spine issues. And then there was such a need at that time for pain management physicians that actually grew in my practice. And through the years, early on, I actually I liked anesthesia for the very fact that my interaction with the patients was short, and then I had them under anesthesia, so I kind of avoided. Yeah, I kind of avoided the patient contact. But actually, as I started doing pain management and saw how much help and benefit I was providing, I actually enjoyed that interaction to see the benefits how I was helping patients. So that grew and grew, and to the point where now I'm full-time pain management.
Are you board certified in any specialty?
Anesthesiology.
And what does that mean, doctor, to be board certified?
That you've completed a residency program in anesthesia and required all the testing requirements that they fulfill, and then also to continue to do continuing medical education in anesthesiology.
Doctor, just so we can go through this more quickly, your background and experience in education. Do we have a CV that you have given us?
Yes.
Can I have J3952, please? May I, Your Honor?
Yes, you may.
Dr. Phillips, I've handed you what has been marked as J3952. I'll tell the court and counsel it is part of a larger exhibit, J2050. But this one is updated with something I think you put on it, Doctor. Remember what that was?
Actually, one of my education was left off, and then there were some minor changes in actually the wording of some of the pain societies that was listed.
Is this an accurate representation of your education and experience?
It is.
We'd offer J3952, Your Honor.
No objection, Your Honor. J3952 will be admitted into the evidence.
Thank you, Your Honor. Just very briefly, Doctor, we've been here, I think this is our 33rd day, if I counted correctly. So everybody's eager to get out, and I don't want to take you through grade school and everything you ever did in your life, but can you just start at college? Tell us where you graduated, where you got your medical education, any postgraduate training.
Okay. I first went to Eastern Oklahoma State College, which was very near to where I lived in Eastern Oklahoma.
You in Oklahoma, born and bred?
I was born here, lived here my entire life with the exception of 1 year when I finished medical school and I did my internship in the Arlington area.
Thank you, Doctor. I'm sorry I interrupted you. Please go ahead.
So I spent my first 2 years at Eastern Oklahoma State College in Wilburton, Oklahoma. Then I went to Southwestern, where I was in pharmacy school for the next 2 years. That's a total of a 5-year program. I was accepted into medical school after 4 years, and then went to Oklahoma Osteopathic College of Medicine in Tulsa, Oklahoma from 1979 to 1982.
Did you then do an internship or residency?
Yes, I did a 1-year rotating internship in, like I say, that Arlington area, and then started my residency in anesthesiology in 1983 through 85 at Oklahoma Teaching Hospitals.
So you had the good sense to leave Dallas and come back to Oklahoma?
But that was the plan all along, yes.
All right. Are you the only doctor in your family?
No, I'm blessed to have a brother that is also an anesthesiologist, and he's one of the reasons why I went into anesthesia. He's 2 years older than I, but 3 years actually ahead of me in practice. And then I'm proud to say that I have a son that is in his first year of residency at Baptist Integris.
Congratulations.
Thank you.
Can you tell Judge Bachman a little bit about your family?
Yes, I grew up in southeast Oklahoma, a little town called Hartshorn near McAllister. My father actually has a GED. He was in construction.
Did you just have the one son, or you had more?
No, I have two, but I always say my father's my hero because he put 3 boys through college and 2 through medical school. So, but I'm married, been married for 15 years. We have 5 children, ages from 32 to 22.
Do you currently practice medicine, pain management medicine, and if so, where and under what title?
I practice in South Oklahoma City. My Comprehensive Pain Center is the name of my clinic, and I think I've been under that title since 1990. I've been in various locations, but all in a several mile area in South Oklahoma City.
Doctor, you say you practice primarily pain management since 1990?
No, in 1990 when I first had my first clinic, and at that time it was part-time. I was still actively doing anesthesia at Southwest, what is now Southwest Medical Center, as well as all the major hospitals in Oklahoma City, because our group provided anesthesia coverage for all the cardiovascular surgeons throughout Oklahoma City, as well as like heart transplants. We covered that. So that remained an active part of my, in the primary source of my practice through the 1990s.
And when did you then switch over to exclusively doing pain management?
Like I say, it was a slow process of where I always had, when I opened my clinic, it was 1 day a week. I practiced pain management, and then by the late 90s, I think it grew to 2 days, and then 3 days, and then I think my last anesthetic now has been 5 years ago, and I was only, at that time I was working with one surgeon a half a day a week, just because we'd had a long-term relationship, and I still wanted to kind of keep my hand in it, but finally said, okay. I went to full-time pain management practice.
You finding any shortage of people in Oklahoma who need treatment for chronic or acute pain?
No. I'm often asked by physicians about needing referrals, and I'm like, believe me, we're doing just fine. That if anything, it's difficult to get all the patients that's being referred to me in. So, and that's, I think, in general, the what the other specialists in, at least in my area and through the state, and talking to them, there's no shortage of patients to go around in chronic pain.
Can you please just briefly tell the court what chronic pain is, at least in your experience and in your practice?
While pain, this is an expression I like to say, while pain is a symptom, chronic pain is more about the patient's suffering and their losses. Patients with chronic pain have to deal with this usually every day of their lives. We all have pain that we deal with from time to time, and we can accept that knowing there's going to be an end to this. In a few days, this bruise, sprain, or recovery from surgery is going to be over with, and I'm going to get better. So that's easy to accept. Patient in chronic pain does not have that hope. They understand that they have a condition that's going to be with them probably the rest of their life. So there's obviously the suffering they have, but then they're also dealing with the losses. And by losses, I mean oftentimes they've lost their job. Sometimes they've lost their house, lost family. But every one of them will say that they have lost their quality of life. Things of just going to dinner with family or just spending time with their family is difficult for them. And then they also have to deal with the stigma of being chronic pain, and particularly if they are on opioids. They're oftentimes saying different, whether it's a family member, friend, or when they go to the pharmacy, they're actually treated like a drug addict and are told you don't need these medications. So they have a lot of stigma that goes along with this. So there's a lot more than just the pain that goes along with it. It's the psychological and the losses that they deal with every day in their lives.
Thank you, Doctor. Do you also hold privileges at any local hospital?
Yes. At one time, like say when we were performing the anesthetics for all the, not all, but heart surgeries in Oklahoma City, I had privileges, I think, at every hospital from Norman to Mercy. Now I have privileges at Surgical Hospital of Oklahoma, Southwest Medical Center, Integris, Community Hospital, and OCOM Hospital.
Doctor, do you receive referrals from other physicians in your pain management practice?
Yes. Before a patient can get into my office, they must have a referral. We do not take, someone can't just call on the phone and say, I want to come see you for my pain condition. We require them to have a referral from a physician, and those are either primary care physician, specialists such as orthopedic specialists, spine surgeons, or rheumatologists. Those would be my biggest areas of referrals.
Given your referral network and the fact that you work at hospitals, are you familiar with the practice of medicine in the Oklahoma City area as it involves pain management?
Yes. I feel like I'm very well qualified to speak of the standard of care in Oklahoma.
What licenses do you hold, Doctor?
What license?
Yeah.
Well, licensed to practice medicine in the state of Oklahoma. Have a competency certificate in controlled substance management. Also, and then as I say, I'm have a board certified in anesthesiologist. I also have my X waiver, which allows me to treat patients with buprenorphine for addiction.
And are you registered with the DEA to prescribe controlled substances, the DEA and the Oklahoma Bureau of Narcotics?
I am since, I think, 1984.
Can you tell the judge briefly about any professional associations of which you are a member?
Yes, I'm a member of the Oklahoma State Medical Association, the Oklahoma Medical Association, the American Society of Anesthesiology, American Osteopathic Association, American Society of Anesthesiologists, Society for the Practice of Pain Management, American Society of Interventional Pain Physicians, American Academy of Pain Medicine, and then the American Osteopathic College of Anesthesiology, as well as being the president of the Oklahoma Pain Society.
We would offer at this time, Your Honor, Dr. Phillips as an expert witness in the subject of pain management. and the practice of medicine in that area in the Oklahoma City and Oklahoma areas.
State has no objection. Dr. Phillips will be recognized to render that expert opinion.
Now, the good news, Doctor, is you've been recognized as an expert in this court, and the bad news is I get to ask you questions about opinion that you hold. Did I ask you to come and testify to Judge Bachman in the area of pain management?
Yes,
And did I agree to compensate you for that?
you did.
Can you tell the judge what your compensation is for the work you have done with me?
For preparation time was $350 an hour. Any preparation time with the attorneys was $450 an hour. And for a court appearance or to testify in court was $10,000 a day.
Doctor, I understand having to put up with lawyers, you want to charge money, but how did you come up with those rates?
I actually called a colleague of mine that has experience in testifying and simply asked him, how do you charge for these things? And he gave me the numbers, so because I had no experience in it.
Have you testified in court before?
No.
All right, well, I'm sure everyone will be gentle with you. Doctor, when a patient comes to you with chronic pain, do you have a regimen you go through to accept them as a patient?
Yes, we have a very thorough screening process. Like I say, we require a referral from the patient, and then a process that we go through before, prior to accepting a patient.
May I approach your honor?
Yes, you may.
Have we prepared some slides that kind of go through this?
Yes.
I'm going to hand you those, and I'll just hand them all to you at once, and we can mark them as a single court exhibit.
It'll be marked as Court Exhibit 215.
Janice, can you put up the steps taken before writing an opioid prescription that the doctor was just talking about? Yeah, that's. Is this one of the slides that you prepared to explain to the court the procedures that you exercise in accepting a patient?
It is.
Just feel free to go through those and tell Judge Bachman either some or all of them that you consider important for your testimony.
Okay. So as I say, before accepting the patient, they have to have a referral. We then do a background check on them to see if there's any criminal activities that particularly are related to any drug arrest. And then we, if they are accepted, we have them do a risk assessment tool, which is the one we particularly use is called the SOAP. It's a 22 question that asks questions about their backgrounds to help with the risk of that patient having any abuse or misuse of medication. Prior to any prescription for an opioid, we require a psychological evaluation by a psychologist that he does more testing on the patient and then gives us a written letter saying, in his opinion, that he sees no contraindications psychologically that the patient would be at increased risk for opioids. And with every patient that every doctor does, we do when we see the patient, we do a very thorough history, physical examination. We review for any contraindications that they might have for any of the treatment modalities that we're going to do, including opioids. Ask them about their comorbidities, if they have, whether it's liver, kidney disease, that type of thing, allergies, or any potential for drug-to-drug interactions that may be there. One of the things that's always important, not at the time prior to seeing the patient, but once before consideration of any treatment, is reviewing of insurance, or because every insurance company has their own requirements of what they will pay for, not pay for, whether that's a modality or a particularly drug. We always check the PDMP prior to prescribing any opioid, and at our office we check that before on every visit that we're going to prescribe an opioid. We will check that. I think the state law requires you to check it every 6 months, but in our office we check it on every month or whenever we are prescribing that. We use random urine drug screens to check that the patient is taking their medication appropriate, that medication we're prescribing is in the urine, and that there's nothing that's not supposed to be in their urine is there. As by law, and even before the law, we have a pain medical agreement with the patient that outlines our expectations, what the patient is expected to do or not do. I have an opioid consent which specifically details the risk of opioids. I read that statement in full to them myself and have them ask them if they have any questions and sign that. And then the last thing, which is probably maybe the most important part of all this process, again, is all these other things can help me. This last thing is about myself and the patient face to face, of where I'm counseling them about their medications, what our expectations are, and what the goals of these medications are, or whatever the treatment options are. It's one of the successes of our treatment is setting the expectations to a patient, because oftentimes the patient's expectations when they get there is, I'm going to be pain-free. We clear to them, well, that's a great goal to have, but if they're in chronic pain, that's not realistic. Our goal is to increase their function, have them do things that they have not been able to do in the past, improve their quality of life, whether that's spend time with their family, to go to dinner, or just interact with their family. And then our goal also is to try to decrease their pain. But if you set these expectations up before ever starting a treatment, then your success rate is much better.
Doctor, can you tell me what kinds of pain patients that you see in your clinic?
The majority of my referrals fall in the categories of spine injuries and with sciatic type pain, osteoarthritis or rheumatoid arthritis patients, and patients with neuropathic pain or nerve pain like diabetic neuropathy and other neuropathy patients.
What percentage of the patients you see would you classify as having chronic pain?
70%.
Is one of your goals to deal with the patient's functionality?
Yes.
Can you explain to Judge Botman what you mean when you say functionality?
Okay. Function can mean several different things, and I think traditionally when someone says function, they say, well, can you walk further? But it's much more complex than that. Function is a different process for every patient. In some person, it may be returning to work, which is, to me, is the ultimate goal for someone, is where I can get them to return to work. For another individual, they may say, I like to play golf. I'd like to be able to play golf occasionally. I understand it'll hurt, but I'd like to be able to do that. I can't do that now.
There are people in this courtroom that feel exactly the same way.
But for a lot of people, it's much smaller than that. Just to be able to get out of bed, to do their requirements of dressing themselves, taking a bath, or even to go make themselves lunch. Such simple tasks as that, they're not able to do that, but with the treatment and the modality that we do, they're able to increase that function. The other part of function that is not typically thought of is just their mental capacity to function. I say they have this stigma, they have the all the losses that they have dealing with. So in my mind, while you can't measure this, I call it hope, giving them hope that yes, I have this, but I'm doing better and I can move forward.
Doctor, what tools do you have in your toolbox to accomplish those goals? And I think we actually have the slide. It's probably got a toolbox on it.
So, as it says at the top there, treatment of pain is individualized. It's always about the patient in front of you. It's not a checkbox A, treat with circle B. It's individualized, it's multimodal. As you can see at the bottom, we have several treatment options and multidisciplinary. And these are the different groups along the bottom. These may be occurring simultaneously. We usually have what we call a step therapy, where we start with the least aggressive, the treatments that have the least risk. We always base things on what we call the risk-benefit ratio. So we start with the least invasive and work our way up towards things with higher risk. And like I say, these things can be going simultaneously.
When you say medication there on the one box, what kind of medications are you referring to?
There's multiple medications, again, starting at as simple as Tylenol, anti-inflammatory medications like ibuprofen, Aleve, naproxen. The anticonvulsants are medications that we use off-label. They've been around forever. This is gabapentin, but it's well accepted in the literature that we use gabapentin and Lyrica for the treatment of neuropathic pain. Again, antidepressants, Elavil or amitriptyline has been around forever. We've used those forever for the treatment of chronic pain, particularly neuropathic pain. Finally, a medication called Cymbalta actually has an indication for neuropathic pain, but we've used those off-label forever. Musculoskeletal agents, use of anxiety medication, sleep medication, and then finally, if when we try to accomplish, when we're talking about just medication, we try to accomplish as much as we can with the top group, and then we'll say, okay, if we can decrease their pain by 40% with that, or 30%, whatever it is, then we address opioids. And sometimes some of these medications above are contraindicated because of the patient's comorbidities and allergies and that sort, so we have to end up with opioids.
As I recall, you were talking about restorative therapies. Can you tell the court what you mean by that? I think we have another slide.
Yes. Simple things at home is the stretching exercises, heat and ice, but then physical therapy is a large part of pain management, whether it's acute pain or chronic pain, and they have multiple modalities that when they're in physical therapy, whether it's traction, ultrasound, stretching, and the exercises they can perform. Bracing is another part of these modalities that we use in treating patients, particularly with spinal pain.
You mentioned interventional procedures. Can you tell the court what that is?
Yes, this is almost a specialty in itself, and we do have pain management physicians that only do interventional. I like to, in my practice, say it's one of the many tools that I use, and that includes whether it's joint injections, spinal injections such as lumbar epidural steroid injections. There's procedures we do for joints where we can actually ablate the nerve, burn the nerve, that gives them long-term relief. Neuromodulation, which is spinal cord stimulator, that we help with patients with back and extremity pain. Intrathecal pumps, which is a implant that we actually can put various different medications in, and then slowly released into the spinal cord or spinal canal, where it gives excellent relief.
And then behavioral health approaches, I think that was another one in the tool.
Yes, and this is a very, very important part of, particularly when it comes to chronic pain, whether it's biofeedback, where the patient can actually meditate to learn how to help them with their pain. The acceptance and commitment, again, as I spoke, part of my education process, but also when they hear from someone else, is them learning that they have this painful condition, it's chronic, learning to accept it, and committing to living with that as the best they can.
And then I think the last one was an integrative health approach. Can you tell the court a little bit about that?
Yes, a lot of these modalities have been around a long time, but they have limited access. But acupuncture, we mentioned bracing early, massage, and then manipulative therapies, which is chiropractic and osteopathic physicians perform, which is also very, very beneficial for patients with chronic and acute pain. And then yoga is, or the Tai Chi and spirituality are all things that can help a patient dealing with their chronic pain.
Now, doctor, in this case, we're going back to medications, opioids. Can you tell the court what opioids are, at least as you understand them?
Opioids is a scheduled medication that originally was derived from the opium plant. Now we have semi-synthetic opioids as well as totally synthetic opioids. Like I say, they are in different classes based on their risk of abuse or addiction, and they're used for the treatment of acute as well as chronic pain.
Doctor, in this case, I represent Janssen. Have you had a chance to prescribe in the past products manufactured by Janssen?
Yes, all the way back to my residency, the mainstay of all anesthetics is the use of an opioid, and at that time the Sublimase or fentanyl that we used. So almost exclusively every anesthetic consisted of providing a fentanyl or another opioid.
Doctor, have you prescribed in the past Duragesic?
I have
How many times?
multiple.
Have you prescribed Nucynta and Nucynta ER?
I have.
And have you prescribed Ultrax?
Yes.
Does this exclude all the other opioids, or have you prescribed other opioids as well?
You know, I prescribe, I don't want to say a large list, but I prescribe also the other medications, whether it's morphine, hydrocodone, oxycodone, buprenorphine products, even Demerol, and a few others.
Thank you, doctor. Based on your knowledge, training, and experience, do you understand that opioids have risks associated with their use?
Yes, going back to medical school, that we are taught basic pharmacology. And I think this is still the same today. In speaking to my son that's just recently finished medical school, since I'm in the field, I tend to talk to him about that particular area more than other. That has not changed in the last 35 years since I was in medical school. Now you're taught pharmacology on all medications, and part of that training when it comes to opioids are training of the risk that goes along with that, including addiction.
Doctor, when you decide to prescribe a drug, do you check the label, approved FDA label, to check for the indications and the risks associated with that drug?
With a medication that I'm familiar with, I don't always check it prior to that, but if it's a new medication to me, and particularly if the first time I'm going to prescribe something, I will go completely through the drug labeling, and oftentimes even in a medications that I'm very experienced with, a situation comes up where a patient has a comorbidity, they list a new drug that they're on, and I have to check to see if there's any drug-to-drug interactions or contraindications to prescribing that, And the source to go to is the FDA labeling or the package insert. Also at hospitals, when I practice there, at every nursing station or the doctor's area where the doctors did their work, there was always PDRs, which has a complete list of all the FDA labeling for all products that we would refer to. So I like to say that's our Bible and the source for finding any information, ultimate resource for determining or finding the information on a particular drug.
Doctor, I want to get through this without going through the labels yet again, but you understand that those labels tell you that opioids carry, class 2 opioids carry the risk of abuse, addiction, diversion, misuse. You understand those to be some of the risks?
Yes, and these are, as I say, in my consent that I read to every patient, that's included in that list that I read to them.
But you choose to use opioids anyway?
Yes, with any treatment modality, whether it's interventional, surgery, or any medications, we always have to assess the risk-benefit ratio. What are the risks of this particular treatment versus the benefits of it? So in opioids, after assessing the patient and making the determination, other modalities have failed, other medications or treatment options have failed, and we consider opioids, it is still a very good treatment for the treatment of pain, and in closely monitored patients, that risk of addiction, abuse, and overdose are quite low.
All right, thank you, doctor. I want to take you back now to the first of your medical education. When you were in medical school, you mentioned to the court that you were taught about pain medications.
Yes.
Was pain being treated back when you were in medical school?
Yes.
How has the treatment of pain or chronic pain changed since you went to medical school and then watched it evolve in the 90s up to now?
Well, fortunately or unfortunately, with my age, I've been through this whole process since the early 1980s. I think the American Society of Anesthesiologists only started the fellowship or the specialty of pain management, I think, in 1978. So prior to that, it wasn't even a specialty. So as the evolution of medicine grew, whether, and this includes orthopedic surgery and spine surgery, we're always growing and progressing, and times are changing. There became an awareness, I think, even in medical school, and I was made very well aware of it in residency, that there was a tens of millions of patients or people in America that was treating from chronic pain, and there was a large amount of that population that was untreated. So there was an awareness of all the patients with chronic pain, and with the evolution of medicine, pain management became a specialty, and I think that usually the specialists are responsible for providing CME and education of the primary care physician. So they were educating the primary care physicians on this under treatment of chronic pain and the treatment of chronic pain. So throughout the years
that today chronic pain is still an unmet need in Oklahoma?
Yes, I haven't read the actual number for Oklahoma, but the latest number I saw listed by the FDA was there's 50 million people in the United States still suffering from chronic pain.
Does the fact that there are now people treating chronic pain mean that chronic pain is going to go away?
No. First of all, as I stated earlier, unfortunately, it's unusual for us to cure chronic pain. So, as I say, once you have chronic pain, probably you're going to always have chronic pain with some exceptions. So, that number is not going to change. Also, we have an aging population. So as people get older, they tend to have more pain. So that number will never decrease, shortage of some new treatment that can cure chronic pain.
Doctor, how many patients are being treated at your clinic for problems associated with chronic pain?
I see usually over 200 patients a week, closer to 250.
And do you believe that there are many more out in Oklahoma who may eventually seek your services or need some sort of treatment for chronic pain?
Yes, that number is actually increased greatly over the past several years as more physicians, because of the different, whether it's the CDC guidelines, state regulation by the state board, or statements made by the Attorney General that he's coming after doctors who's prescribing opioids. That fear has left many primary care physicians saying they will no longer treat chronic pain patients and leaving these patients abandoned because there's just so many physicians available to treat chronic pain.
Does it surprise you, doctor, that there are still patients experiencing chronic pain even though people like yourself are trying to treat it?
I'm sorry, could you repeat that?
Does it surprise you that we still see people with chronic pain even though there are people in your profession trying to treat it?
Oh yes, like I say, there's still, even though with, like I say, as the specialty is grown, there still is only a small number of physicians in Oklahoma that treat chronic pain other than interventional treatment. So with the shortage of physicians treating chronic pain, there's still many patients left untreated.
Doctor, can you explain to the court if patients can be harmed if their chronic pain is not treated adequately?
Yes, as I again mentioned before, and it's kind of a recurring theme for me, is pain is about suffering as well as their losses. So as a patient has chronic pain, it affects them mentally, can cause anxiety, depression, and then just the stress that it puts on their body can create hypertension, heart disease, and other problems. So it's just in medical school where we're taught to treat the whole person, not just the disease. So pain definitely affects the whole person.
Is there a risk of depression in untreated chronic pain patients?
Yes, it's common.
Is there a risk of depression even if patients are being treated for chronic pain?
Yes.
Tell the court about that.
Again, as I say, chronic pain usually is a everyday experience that a patient can't get away with. Even at nighttime, we usually assume we go to bed and you do well. Oftentimes a patient with chronic pain, their worst pain is at nighttime. During the daytime you have distractions that keep you from thinking about your pain, but at night they lay down and it's them and their pain. So they suffer through the entire night, a loss of sleep. And again, I talked about the losses. The loss of their, whether it's their income, jobs, their relationship with their families, and their hope. They tend to lose hope. So all this leads into depression.
Doctor, is the treatment of chronic pain highly individualized?
Every patient, again, as I say, it's not a thing of where you check the box of chronic pain and you circle treatment on the right. It's every patient is individualized. You have to interview that patient prior hand. You have to assess what their risks are for any of the treatment options, what insurance coverage are for those treatment options, and then based on all that information and discussing it with the patient, you come up with a treatment plan.
Doctor, we've heard some testimony in this case about how insurance coverage or different health plans may affect the treatment a patient can receive. Can you just briefly explain to the court what we're talking about there? He's already heard some testimony on it, so you
Sure.
don't need to go into great detail.
With every patient, I could have a cure for pain in my back pocket, but if insurance isn't going to cover it, or even if they do cover it, their copay is too expensive for the patient, and that's different for every patient. What I may be afford, the next person can't. That cure that I have in my back pocket is not an option. So with every patient, before, as we get a treatment plan, if I'm going to start something new, consider injection, consider a different treatment, regardless of what it was, even simply as wanting to order an MRI. The next question is, all right, what's your insurance? Let's check and see if that's going to be covered and if it's affordable to you. And that differs with every insurance company, and one of the largest frustrations for every doctor now is having to deal with this bureaucracy of dealing with insurance companies.
Doctor, when you decide to prescribe opioids to a patient, is the opioid you choose, the route of administration, the dosing of that opioid also individualized to that patient?
Yes, we always have to, we take into consideration all things with it, and it's always different for every patient. Does the patient have occasional pain? Is it something that it's worse the first thing in the morning, or is it possibly at the end of their day when they're working they're having pain, or is it what we call around the clock? Do they wake up in the morning with pain, and when they go to bed at night they still have the pain, and they're having to wake up at nighttime sometimes to take medications? So the timing of the pain, the severity of the pain, these are all things that we take in consideration. Also, we take in consideration what that patient's compliance with. Using myself as an example, I can remember to take my pills when I brush my teeth, which is in the morning and before I go to bed. Taking something in between there is always hard for me to remember. A lot of patients are the same way. They have a hard time, particularly in elderly, remembering to take their medications. And in the case of an opioid, just like a hypertension medicine, if you wait until your pain is very severe or your high blood pressure has shot up, your medication is not going to be nearly as effective. So compliance is also an issue that we have to take into consideration.
Doctor, you've already talked about the FDA label as it relates to opioids. You've already talked about how you treat pain with opioids and other tools. Did you bring with you today some examples of patients suffering from chronic pain, obviously de-identified, that you can discuss with Judge Bachman?
I have.
Can we put that up, Janice, just the first one? Can you describe this patient to the court and explain what her problem was or is?
Yes.
And how you went about diagnosing it and what your treatment options for her were?
Okay. This was a lady that was injured at work, injured her low back. She went through conservative treatment. This is prior to me ever seeing her. Went through conservative treatment of injections and physical therapy. Eventually she had a lumbar fusion, and when she continued to have pain after that, in the normal period of time afterwards, she was referred to me for, in the workers' comp system, it's called chronic pain medical management. And as I say, when she came to me, she was taking oxycodone acetaminophen, 10 milligrams, 8 to 9 a day. That's about 120 MMEs of morphine equivalents a day, and was not satisfied with that. So she was taking either 1 to 2 pills or 1 pill that's every 3 hours or less. So she had around-the-clock pain and was taking medications continuously. So after assessing her Other treatment options was not available. I requested on her to do, I think, an injection. This was denied by workers' comp because they deemed her continuing medical maintenance only. I placed her on a fentanyl patch of 12 mics plus 3 oxycodone a day for what I call breakthrough pain. There's always times of the day where patients' pain escalate at the end of the day. Sometimes it's first time, or just based on their activity. It increases, and so we allow a breakthrough pain medications. So with this conversion, she is now down to approximately 75. So we've decreased her medications by 50%, and actually she has done better on this. We've not had to adjust her dosage.
I see that no dose escalation needed. Can you explain to the court what you mean by that?
Yes, and probably to make things clear, this might have not been the exact how we started that. Probably the patch, I did start that, but then we always taper to need the use of the what I call the breakthrough medication. So, but once her dose was established at this regimen, over the past, I think, well, her injury was in 2012, so I assume I saw her in 2012 or 2013. So since that time, she's needed no increasing dose. She showed no tolerance, and she has continued to work as a dental dentist. So she's gone back to work and continued to work and doing quite well.
Okay, doctor, let's put up another one and go through this. We have a 53-year-old male here. Can you explain what we're talking about with this person?
So this goes all the way back to 1993 when he was diagnosed with a tumor on his fibula, the small bone in the lower leg up towards the knee, that required surgery for this. Unfortunately, during the surgery, the perineal nerve was tangled in that, and that had to be resected as well. He then underwent multiple surgeries for grafting, regrafting, working on scar tissue, but still he had this neuropathic pain that was going on with this. We tried multiple therapies, including the gabinoids, antidepressants. The B12 folate is a medication that can help with nerve regeneration, usually not in a large nerve like this. He was not a candidate for spinal cord stimulator because he worked in the electrical field and was around high current electricity, so that was not an option. And he was just started on hydrocodone 10-5 a day, and over the 16 years, and when I say he's been on the same dose, at times he was actually on less. There's a few times where he was actually on a little more, but it's pretty much stayed at 5 a day. And this gentleman continues to work. He coaches his son's basketball or baseball teams, and he's a very active hunter, leads a very productive life. Again, to demonstrate that there's been no tolerance. We've allowed to help this man with his function. He's still working, his quality of life. Like I say, he hunts, coaches his son's baseball team. This is just another example that I could go on every day of patients that benefit from opioids.
Okay, what's the next one? We have an 84-year-old female.
Yes, I think I brought this up just for the fact that to show that obviously senior citizens also suffer from chronic pain. When this lady first came to me, she was in her 70s. She'd had a fracture in her spine of a collapsed vertebral body, and she had surgery for this, but unfortunately they didn't do it acutely, and when that procedure's not done shortly after the injury, it turns into a chronic, painful condition. This lady's goal was, she lived by herself. She said, I want to be able to work in my yard. I've got a small flower garden. I want to be able to do that. So we started her on, again, hydrocodone, acetaminophen. Takes 1 or 2 a day. Basically, she goes out in the yard, going to be active. She hurts afterwards. She's now 84. She still lives by herself. she can no longer drive. And when I saw her a couple of weeks ago, I asked her, I said, "Are you able to work in your yard now?" She's like, "Well, I'm afraid I might fall now just because of my balance, but I still live by myself. I still do my own cooking, cleaning, that sort of activity." So still very productive at 84. And again, she only uses pain medications as needed basis. So not every patient needs escalating doses and needs it around the clock. This lady needs it just as needed.
I notice over here, doctor, you've got a fentanyl patch. Do you have any family members that have experience with fentanyl?
I do. One of the things with my patients that I stress to them, in any treatment, I like to tell them, I like to recommend to you what I would recommend if this was my wife or my mother or my family member. If it's not good enough for them, then I shouldn't be recommending it for you. My own mother went through a period of time approximately 10 years ago where she had a degenerative back. She fell, fractured her knee, and then also had a stroke. This all happened in a 3-year period. Had a stroke and was having upper back issues. A colleague of mine seen her, did some injections on her back, but ultimately placed her on I don't know if it's Duragesic or Fentanyl Patch at that time. And she did quite well and was on it for 3 years. Her activity levels went way down, and she just decided herself she didn't need it anymore, and she stopped it herself. So again, this happens every week where patients stop their pain medications. They don't have withdrawal. While many people can have a dependency on it, not every patient is going to be dependent on an opioid if they take it long term. And my mother's an example of that.
Doctor, let's go on. Next one. We have a 46-year-old male here. Tell Judge Bachman about him.
Yes, this was a man that, again, had a workers' comp injury. After thorough workup, they did a discogram, which helps determine which levels are affected. He had 3 levels that was affected, and the surgeon said, "You're 46. He didn't think that with his pain, that the risk benefit, that he did not recommend surgery and recommended him for pain management." This man, one of the things he was clear from the very first day, he said, "Look, I don't want to get on medications." And I said, "That's great. We need more patients like that." But I said, "Let's talk about other medications, not opioids, anti-inflammatory medications and the gabinoids," which we started. He came back and said, "That helps, but I'm still have a significant amount of pain." I discussed with him spinal cord stimulation, that this is his best option going forward, that it can help with his back pain as well as his leg pain. And in his own words, he said, "This is the first time since my injury that I have hope that I'm going to get part of my life back." Unfortunately, with the workers' comp system, they denied this and saying the only thing you can give him is pills.
All right, doctor, let's go to the next one. We have a 62-year-old female. Explain to the court what you're trying to say here.
This was a lady with multiple things going on. She had chronic back pain as well as a diabetic neuropathy. So she kind of had 2 painful conditions going on simultaneously. And then with all of our patients, we have to take in consideration what their comorbidities are. Again, I said she had diabetes. She was also obese and had hypertension. So her initial treatment started out with injections. We did some facet blocks with ablations to those. Started this medication called Metnex, which is a combination of B vitamins and folate, again, that showed that it was helpful in the regeneration of small nerves. She wasn't a candidate for NSAIDs because they would be contraindicated with someone with hypertension.
What do you mean contraindicated with someone with hypertension?
Well, chronic use of NSAIDs in a patient with hypertension, they've shown that can cause the hypertension to be worse, so it's not indicated for a long-term patient.
And so tell me what you did for this patient.
So, since Nucynta has an indication for diabetic neuropathy as well as other pain, it was a sensible medications to use on her. We started that with, and through the titration period, we had got her to where she was taking 150 of Nucynta extended release twice a day, along with 2 hydrocodone. As we do with all of our patients, we reevaluate them after a period of time to see how they're doing and to see if we can decrease their pain medications. Maybe they've gotten better. Maybe the Metnex or something of their diabetic neuropathy pain is not as bad. We then titrated her down to 100, and after we have to give it time. And we just don't, when they come back next time, we almost expect them to say they need an adjustment period. But after 2 to 3 months, she continued to complain that she wasn't doing as well, and we increased her Nucynta back to 150, and again, she improved. So this is something that we do on all of our patients. From time to time, we assess to see if their needs have changed, and we try to taper them down on their medications.
And I think the court heard testimony earlier about Nucynta being approved for this neuropathic pain, neuropathy.
Yes, for diabetic neuropathy.
And is it the only opioid approved on label for that?
Yes.
Doctor, we've talked about a lot of people up here who have non-cancer chronic pain. Is it your opinion that there is a difference between cancer pain and non-cancer pain from your perspective as someone that has to help people with treatment for it?
No, pain is pain. The underlying cause of that pain may vary, whether it's coming from a cancer, but due to that cancer is affecting an organ, whether it's a bone, the spine, the internal organs, and that internal organ that the cancer is attacking is causing pain. So the pain is different. What is different is the patient. In the case of a patient with cancer, sometimes they're terminal, so we view those patients as different when we're treating them with opioids.
Doctor, you mentioned before you consult the FDA-approved label for information about a medication you have questions about. What other sources do you use to learn about treatments for chronic pain?
Well, obviously, I try to stay abreast of the literature that is being published. As being, again, president of the Oklahoma Pain Society, I have an interaction with many of my colleagues, and part of our regular meetings is discussion on chronic pain treatment. And so, while my best experience with a particular medication is my own experience with my patients, how they have responded, and what side effects they may have. That's usually my best resource for a medications. That's one I was leaving out. Also the just the CME courses. Oftentimes we'll have lectures on opioids or other medications to talk about their risk and benefits.
Doctor, when you prescribe an opioid to a patient, do you just leave it at that, or do you continue to follow them to see how they're doing?
No, they're always monitored very closely, and prior to, as I say, starting any opioid, every other treatment options has been explored, and if we still think opioids are a option, then again we have this education process and counseling that we go through with them. But once it's, we don't ever just start them at a regimen. You purposely start at the lowest possible dose, actually a dose that you almost know is going to be too low, because the worst thing you can do is start at a dose that could put the patient at risk of an overdose. So we start at a very low dose, we see them back, and then we taper that medication to their need. The same as if you would be treating a hypertension. You titrate that up till you get the hypertension under control. We do the same thing with medications, and we continue to monitor them with like I say, our risk assessment tools, as well as urine drug screens, but more importantly, seeing them monthly to talk to them about how their response has been to this medication, in this case opioids.
Doctor, do you see sales representatives in your practice?
I do,
That's your choice?
yes.
As I recall, I looked through this and you're visited about once a month from 2001 to 2015 or 16, something like that, by a Janssen sales rep.
That was what was shown to me.
And tell me why you see sales reps.
They provide information to the doctor, whether it's if there's a new product that's being introduced. Just last month, I never seen this particularly. It was a new drug for constipation, which is a common problem we have in chronic pain. I'd never seen this medication listed anywhere in the literature, and this pharmaceutical rep was introducing it to me. And interesting, she actually gave me some samples, and then probably within a month, a patient came in that had failed the other medication that we traditionally used. And I remember this, again, as we always do, first time I referred to the FDA labeling to specifically see what the indications, risk, contraindications, and that could be. And I initiated that medication. Other information that they provide, though, is particularly on insurance coverage. As I say, that's our biggest headaches as physicians, is trying to decide what is going to be covered by the insurance. So they can tell us what the latest insurance coverages are for their medications, and that's changing monthly, whether medications are added and sometimes taken off. We have patients that own something that's been well controlled for months or years, and insurance company just drops it, and so we have to treat something else. And then from time to time, I have a question. A patient may have a comorbidity or had a complication or side effect of a medications, and in reading the labeling and doing my own research, I can't find an answer to that. They can submit that to the pharmaceutical company, and then you will have a written letter to you citing what's the articles or anything to substantiate that particular problem or question that I had.
Doctor, do sales representatives influence your prescribing decisions?
No, I'm not influenced by the sales representative. Like I say, they provide me information. What influences my decision is that patient in front of me. Every decision I make is between myself and that patient, and we're trying to decide what is in their best interest and what treatment modality is best for them. That's what influences me.
Doctor, I want to confine my question to Janssen sales representatives. Has any one of those people, male or female, ever told you that an opioid was more beneficial or less dangerous than you in your practice have found it to be?
No.
So, doctor, do you continue to follow up your patients? You've talked about the decisions you make before you put them on an opioid. You use risk tools to help you in that regard?
Yes. In addition to, I told you, we have a very extensive first-time package insert and material that the patient fills out. But on every follow-up, they also have other questions that they answer. Part of that is, have they had any changes, been to any other doctors, has their medication list changes, and then we have the risk assessment tool, the SOAP tool, the 21-22 question that we ask them to help us in if there's been any change in the risk assessment. Another question, we call it our spasm form. I'm not sure where that name come from, but it's
Do you
actually,
have that slide, just in case he needs to refer to? I'm sorry, I should
yeah, the
have thrown
spasm
this
tool,
up.
and that's more of an assessment of their function. On our first initial thing, we actually asked them what activities are they able to do, and then list activities that they would like to be able to do. So this tool kind of goes through some of the questions on function and helps us assess if we are increasing them. Urine drug screens, as I say, are something that we do periodically, and many things can be obtained from this. Is the patient taking their medication? Is their metabolite? So sometime a patient, parent drug may be there, but there's no metabolites, which tells us that the patient either just took that medication right before walking in, or possibly even might have shaved some off the pill into it as a way to deceive us to thinking that it's a positive. Other things we look for, are there other medications in that urine drug screen that we are not prescribing, whether that's illicit drug or other medications. We check the, it's not there, but we check the PDMP on every visit, on every patient, if they're being prescribed a opioid. But then again, most important, these are all tools that can help us, but it still ultimately comes down to my face-to-face talking with a patient. How are you doing? What are you being able to do? Sometimes a patient will check on a box and, of, I'm no better, I'm still limited. And then you talk to them and ask them like, well, are you able to go to the grocery store now? Yeah, I'm able to go to the grocery store. Are you cooking your own meals? Yeah, I'm cooking my own meals. Well, you weren't able to do this before, so it is helping. Well, you're right, but I still have pain. And again, that's where we have to counsel them again. You're always going to have pain. We're trying to increase your function and quality of life. And do you agree we are doing that? Well, yeah, you're doing that. So again, it's that face-to-face time that is most vital in every patient.
Doctor, we prepared a slide to give the court some idea of what your patient mix is in terms of insurance or workers' comp. Janice, do we have that? And is this that slide?
Yes, I do not limit my practice. There may be the rare insurance company that I'm not on their plan, but that's very limited. Otherwise, we take all patients.
And doctor, I think the court's heard quite a bit about rules that apply to Medicaid, Medicare, private insurance. Of course, there's private pay down there, but I don't know that we've talked any about workers' compensation. And you put up an example of a patient you're seeing under workers' comp for continuing treatment. Janice, do we have that slide for the workers' comp for doctor? Yes, continuing medical maintenance, and I put the definition of it up there. When you are dealing with workers' compensation, do you have to deal with this rule about continuing medical maintenance?
Yes, the key word is continuing pain medical management. I've pointed this out to many legislatures, we pointed out to the Attorney General himself, that this is the limitations that we have in treating with workers' comp, in that why it says it means medical treatment that is reasonable and necessary to maintain a patient's condition resulting from their injury after reaching maximum medical improvement. Well, that sounds good. Sounds like I can treat them. Next line says, but it doesn't include diagnostic tests, surgery, injections, counseling, physical therapy, or pain management devices or equipment. In other words, you can give them pills. So this has got me handcuffed and the patient handcuffed when it comes to what we can do to treat workers' comp.
Do we have another demonstrative there?
And if I may expand, yeah, so here's an example.
Using
of-
your original boxes there, Doctor,
Yes.
can you explain to the court what's available and not available to you
Again.
under that definition?
It's easier to say that, easier to say what is available, and that's just medications listed over on the left. Every other treatment options, modality that we have that can help a patient is not available to them. And even a bigger barrier with these patients is they may have a private insurance and we say, well, we'll just do it under private insurance. Not so. The private insurance, particularly Medicare, will say, this is a workers' comp insurance case, and it must be covered by workers' comp. So they can't even go to their own private insurance to get care for the chronic pain condition. So again, this is a prime example of how we are actually forced in some cases to only use medications when other treatment options would be better suited for a patient.
All right, thank you, doctor. How do you keep current on the risk and benefits of various opioid pain medications?
Again, as I stated, our primary source that I always refer to is the FDA labeling. Also, from time to time, if there's been a change in the labeling, we will be notified of that change by the company that they have a change, whether it's a different risk for it or an indication for that medication. Sometimes the indications for their drug changes. Also, just staying up with current literature, as well as speaking to my peers and colleagues at various meetings.
Doctor, do you take CMEs?
Yes.
And can you just tell the court briefly what you get from CMEs?
CMEs are very strict in that because I have provided lectures for CMEs, you have to submit your material to whoever is sponsoring that continuing medical education for them to approve.
And are there CMEs in Oklahoma that deal with opioids?
Yes, it's very common now.
All right. And based on the experience you've had, doctor, with meeting with other doctors and dealing with them on a referral basis, have you found that they are also aware of the risks and benefits of opioid medications?
Yes, as I say, I interact with doctors all the time at meetings, and there's not a week that goes by. Since I am the president of the Oklahoma Pain Society, there's not a week that goes by that I do not get a phone call from a physician asking me a question. So I'm very aware of the standard of care and what other physicians are doing in Oklahoma. And again, as I stated, that goes back to our very basic training in medical school, that physicians are very aware of the risk of addiction and the other risk of opioids.
Does this include the primary care physicians that refer patients to you?
Absolutely, they're just as aware of it, because I deal with them on a regular basis also.
Doctor, you've also engaged in speakers programs.
I have.
Tell me about that. Tell the court about that.
There's several medications that the pharmaceutical company to ask me to speak on their behalf to inform physicians and other providers about their product. Before this is done, I have specific training on their product, and all the material that's provided is approved by the FDA, and was told specifically that we can only provide the information that is provided on the slide deck that the FDA is approved, and we have to stay on label and only contain that materials.
Doctor, you've talked now about Nucynta and Duragesic being the transdermal patch. Do you find it to be advantageous in certain situations?
Yes.
Can you tell the court why a transdermal delivery system would be advantageous in a certain situation?
Well, first and foremost, it's indicated for around-the-clock pain. And as I stated, people with a large amount of patients with chronic pain, they have pain around the clock. So even after they go to bed at night, they may wake up 3 or 4 hours later requiring enough pain that they need to take something for that. So Duragesic provides that around-the-clock coverage. It's good for patients that have a compliance issue, like myself, that can't remember to take pills. You put that on, it gives an even state. And since it's slowly released, that has several benefits in itself, in that it gives a steady state. You don't have peaks in valleys. Like you take a pill and 30 minutes later you have this large peak of plasma levels, where a patient then could have side effects or be drowsy from that, and then towards the end it's actually falling below where they're getting therapeutic value. With the fentanyl, it's a steady state over 72 hours. That is a big benefit. The other, in my experience, in treating it, since it is a slow onset, you don't get an immediate release, that has helped in the abuse potential of it.
Doctor, you talked about Nucynta, and the court's heard some testimony about that product being tamper resistant. Are you familiar with that term?
Yes.
Can you tell me whether you believe, in addition to the neuropathic pain indication, whether that is an advantage to a medication if it is tamper resistant?
Absolutely. Anytime we can provide a medication that is at lower risk of someone that is wanting to abuse a medication and taking it not as prescribed, whether they're wanting to crush it and snort it, some way or another dissolve it and inject it, or just even if they're going to take it by mouth, crush it and take it by mouth so it has a immediate effect. That is always desirable, and we always want to use that type of medications. Janssen came up with a product where they came up with a very, very hard shell product, and they took a laser and drilled a little tiny hole in the end of it. And the only way the medicines come out is when the patient takes it, fluid from the GI system goes in and dissolves, and then it's slowly released out through that little laser hole that they've drilled in there. If a patient does, anything can be crushed. So if they do crush it, the materials in the capsule are then mixed with the product, and making it very hard to snort or try to inject.
Doctor, you indicated you've also used Ultracet.
Yes.
Can you tell the court what that is?
Ultracet is a Schedule 4 pain medication that also works on the mu receptor as well as on the norepinephrine and serotonin uptake system. By being a Schedule 4, that means it has less abuse potential with it. So
You say Schedule 4, what do you mean by Schedule 4?
all medications are placed in by the DEA in a scheduling system, with Schedule 1 being the illicit medications, and then Schedule 2 are the highest risk of abuse potential, and Schedule 5 are actually cough medications. Some over-the-counter medications have the least potential for that.
What is the advantage, if any, of having a drug like Ultracet in Schedule 4 that you have in your armamentarium or toolbox?
Again, we always want to start with the lowest dose, the safest, or the medication with the least amount of risk. So a patient with Ultracet is indicated for, and how I use my practice is for moderate pain, not severe pain. So we use it as a place to start with patients, because it is has less risk of abuse potential with that, and that's usually where I'll start with, is a medication like that.
And can you give the court some example of the kinds of injuries that you might treat with Ultracet?
Sure. Again, oftentimes in acute injuries, whether someone has a broken bone, depending on which bone it is. Also, in an acute injury, whether it even is a strain or sprain, which those comes in all varying degrees, but if a patient comes in on crutches, can't bear weight, has a purple ankle that's swollen up like a basketball, and obviously is in pain from this, Ultraset is a great consideration for that patient.
Doctor, do you believe that opioids are appropriate for the treatment of chronic pain?
Yes, in my practice, I see this every day. I have patients every day, patients that are improving their quality of life and function because of opioids.
Does that include the treatment of chronic pain that is non-cancer or end-of-life related?
Yes.
Do you believe that the benefits of opioid medication for the treatment of chronic pain outweigh the known risks of those drugs for abuse, addiction, and misuse in the patients in which you choose to prescribe them?
Again, it's individualized. We have to take every patient that's in front of me, and with the risk tools that we've discussed, and also my face-to-face interaction with that patient. But if I, in those patients, in a closely monitored patient, those risks are minimized, and yes, those benefits do outweigh the risk in many patients.
Doctor, how many of your patients are Oklahomans?
Are Oklahomans?
Yeah.
99%. I have a few workers' comp patients that the workers' comp system requires them to come here from out of state, as far as Missouri. And
Doctor, can you give the court some idea of the percentage of those patients suffering from chronic pain who have been on or are on opioid medications for the treatment of that chronic pain?
Yes. I would say 60 to 70% of my patients are on opioids or are suffering from chronic pain, and the majority of them are on opioids.
Do you believe that they would be adversely affected if opioids were not around to treat their chronic pain?
Not only my patients would suffer considerably, but as I say, it's already happening in the state of Oklahoma that many patients are being left untreated now that were being treated by their physicians, and now their physicians are no longer prescribing opioids because of the fear that I mentioned before. So it's already happening.
And can you tell the court what some of those harms would be?
Again, as we talked with just the suffering of increased pain, the losses that go along with that, whether that's loss of work, loss of family, just their overall health, as we've talked about the stress that it puts on them. There's shown to be a risk of increase in suicide in patients with chronic pain, so I'm sure we'd have an increased number of suicides in chronic pain patients if those patients were left untreated.
Doctor, I believe that's all I have for you. I will turn you over to one of the people over here. Would you please answer their questions?
I will.
Thank you. We'd offer that court exhibit, Your Honor, which I have probably wholly messed up in order, but I would offer it as court exhibits next.
We'll take that up at the close of our
Please don't tell Amy I did that.
proceedings. No comment. Let's go ahead and break and resume again at 10:45.
Thank you, Jim.
Mr. Beckwith, you're recognized for cross-examination.
Thank you very much, and may it please the court. Dr. Phillips, my name is Brad Beckworth. I represent the state of Oklahoma. You and I have never met before this moment, have you, sir?
No, sir.
Now, you recognize the gentleman walking in the door here just a second late. That's Attorney General Mike Hunter. You know him.
We met on one occasion.
Yeah, in fact, you went and saw him talking about some legislation recently, correct?
Correct.
Now, just a few things. I don't think this will take all that long. You were asked about some of your call notes that were shown to you. Do you remember that?
Yes, sir.
Did they show you the call notes that they've used with all the other doctors in Oklahoma?
The call notes of other physicians?
Yes, sir.
Not that I'm aware of.
And did they show you all their internal marketing documents that were the reasons, the business reasons why Johnson & Johnson and Janssen sent sales reps to talk to doctors?
I've been provided a large amount of material. Some of that was marketing materials. I don't know if it's marketing material. I'd say more of promotional materials, but I've reviewed a lot of information briefly.
But have you read their internal documents, studies, information by third parties that they used that talked about how they were to use sales reps in the efforts to influence doctors? Did they show you those documents?
I'm not sure if you've got something specific. I can tell you if I saw it or not.
Nothing comes to mind.
No.
Okay, perfect. Now, you mentioned the OSMA. Tell the court what OSMA stands for.
Oklahoma State Medical Association.
And you remember that?
I remember.
You're a member of
Yes,
that?
yes.
Okay. Now, I don't know if you were there, but let me ask you, were you there when the OSMA invited myself and Reggie Whidden, who's to my left, and Attorney General Mike Hunter, to come and speak about this lawsuit and the opioid crisis in Oklahoma and gave us a standing ovation when we left?
No.
You didn't know about that?
I don't know if I was aware or not. I know I didn't attend.
Did you know that the board members of the OSMA are unified in their support of the Attorney General's position in this lawsuit?
Excuse me, Your Honor, I object to source facts, not in evidence.
Ask him if he knew.
Overruled.
No, I'm not aware of that.
Now, you mentioned I think you were referring to legislation. You were talking about some of the things that have happened and doctors being afraid to prescribe and limits that have been put on prescriptions. Is that right?
Correct.
Did you know that the OSMA fully supported every piece of legislation that has been passed in the state of Oklahoma over the last couple of years related to opioid prescribing?
Yes, and so has the Oklahoma Pain Society.
Okay, great. And you also were talking about some of the things that you do in your practice, but you didn't give a time frame on it. So, you were talking, I think one of the slides they showed, you had all these medications and then opioids were at the bottom, and then you talked about things like urine screening and a patient agreement and reading the labels. You remember all that?
Yes.
You didn't give a time frame, though, when you started doing that. That was a pretty comprehensive and conservative approach you're taking to opioid prescribing, true?
Yes.
But when did you start doing all that was on that slide?
Again, it wasn't a one-time thing. As I spoke with the evolution of medicine, we are continuing to strive. Hopefully, this time next year, that list will be changed. Not one thing. Not all of those things changed at once. It's been a progression, and that's based on my interaction with my peers. I always want to try to stay abreast with what my peers and what the standard of care is. So those things have changed over time.
So you've become more conservative over time?
No, my practice has always been the same. My philosophy has always been start with the most conservative treatment, and then you progress up the ladder to things with based on that risk-benefit ratio. What has changed, I think, is my screening and monitoring of patients has become more stringent over the years.
So you would agree with me that when it comes to prescribing narcotics in pain management, doctors should be conservative?
Yes, I think that all doctors should, and I think all doctors do follow the approach of start low, start with the things that are least aggressive or with the least amount of risk, and progress to things with higher risk.
And people should never tell doctors that they should be very aggressive in using opioids for long terms and at high dosages.
That's never been my experience.
They should never do that.
I agree they should not do that.
Okay. Now you mentioned your son. Your son's in his residency.
Yes.
Are you going to talk to your son about using opioids in pain management?
We have those types of discussion now.
And would you tell him the same thing, that he needs to use narcotic conservatism with respect to if he chooses to use opioids in treating patients?
Not sure of the word conservatism, but I've been very impressed with what he's already learned through a medical school, that his basic understanding of the pharmacology and understanding of these medications, he has a very good understanding. And with, like all physicians just out of medical school, his practice of using those medications is limited, and that's what he's learning now, is how to take his knowledge from medical school and apply it to patients. But
well, while science has changed over the years, your son's gone through medical school in his residency, kind of like what was happening with you back in the mid-'80s. Both are at a time where folks know we need to be conservative with the prescribing of opioids at high dosage and long duration. True?
Again, it's always been the philosophy in our training to start with the lowest dose, least risk medications, and move towards the higher risk.
Okay. Now, you mentioned that if chronic pain patients lose the ability to have opioids, some, you fear there may be things occurring like loss of work, family, and even suicide, right?
Correct.
Okay. Now, you understand that this lawsuit and the Attorney General's position in this lawsuit has never been to deprive doctors of the ability to use opioids in their prescribing practices if they do so conservatively and according to state law. True? You know that.
I agree with that.
Now, you also said that, I just want to make sure, you were asked a question about whether pain is still, the undertreatment of chronic pain is still a problem in Oklahoma, right?
Correct.
Well, you know that over the last 20 years, the supply of opioids by doctors in Oklahoma has increased. We've had an increase in prescriptions and the volume of opioids being used, right?
Yes, as I say, with the evolution of medicines, as more physicians have become aware of the undertreatment of pain, I'm aware that number has increased.
So the number of prescriptions and the number of pills available in Oklahoma didn't eliminate the perceived undertreatment of pain.
As I said, we do not, our goal is not to cure pain with opioids. So if that number of chronic pain patients will remain the same, because we're not curing anyone of their pain with opioids, but the number may increase because, as I say, we have an aging population, and now we have less physicians willing to treat patients.
Right. So again, the increase in prescribing, the increase in available opioids has not eliminated the perceived problem that pain is undertreated, right?
Well, those are two different questions, I think.
Well, we still have undertreatment of pain in your testimony, true?
Yes.
And we have a lot of opioids in the supply stream, true?
The opioids are being prescribed. Yes.
A lot, more than there used to be.
Yes.
Okay. So prescribing more opioids, having a higher volume of opioids available, hasn't stopped this undertreatment of pain, as you call it.
No, like I say, because we're not curing anyone. We're treating the symptoms and helping patients, but again, we're not going to cure it with opioids.
So while all these opioids being supplied didn't cure it, we do have a problem, an epidemic in this state, true?
I don't use the word epidemic. We definitely have a problem with drug abuse and overdose in Oklahoma.
Is it your testimony you don't use the word epidemic?
No, because it's not a contagious disease.
Okay, I want to make sure the court reporter got that. I asked a question, you said no. You're agreeing. I want to make sure this is very clear. Is it your testimony that you do not use the word epidemic when referring to the opioid crisis.
That's correct.
Okay, thank you. Now, we'll come back to that in just a second. When I asked those questions about loss of work, family, and suicide if opioids weren't available, you know that those things you listed, those are the kinds of things that happen when somebody has opioid use disorder or even overdoses on opioids. True?
I'm sorry, what things occur?
Well, loss of jobs, loss of family, suicide, they're all directly related to being on opioids for a long period of time at a high duration if someone gets opioid use disorder. True?
Only if they develop opioid use disorder, then I agree with you, yes.
Which has happened to tens and tens of thousands of people in this state.
I can't agree with you on that number. I don't know what the number. We definitely have a problem with opioid use disorder. I will agree with that, though.
Okay, thank you. Now let's go back to a few things here. You said, I think I heard you say, that you received CMEs. You've been at CMEs as a participant.
Yes,
I think you also said you've given CMEs.
correct.
And, you know, I think you gave a CME for the OSMA. Is that true?
Yes,
Now, I see you got one of these wide collars on with a good tie. That's a double Windsor knot, right?
if you say so.
Well, it looks good on you. The reason I asked, the folks that were sitting here know I ordered all these shirts for this trial board here for so long, and I didn't know how to tie one. So I've been trying to tie a wider knot for almost 2 months. And this is a true story. Wednesday of this week, I finally got on YouTube, and I found some dude that was on the internet showing how to tie one of those. True. And I tried to tie this one this morning by memory, and I had to go back to YouTube. You ever use YouTube or the internet?
I have, not regularly, though.
Well, you know, it's kind of funny, like finding out how to tie a tie. There's a lot of stuff out there on the internet if you just look hard enough, isn't there?
You can find out most anything.
Yeah, so one of the things I did last night about 10:30 was I found you on the internet. Your Honor, may I approach?
Yes.
Your Honor, this is an agenda item we found last night. It was not on our exhibit list. We're going to offer for impeachment. Here, let me just lay a predicate to law for what's in that agenda. So, sir, as we established, you are a member of the Oklahoma State Medical Association, and you have presented as a presenter on opioids and the opioid problem we have in the state of Oklahoma, correct?
Correct.
And what I just handed you is an agenda for a CME miniseries that occurred in Oklahoma on October 28, 2016. Do you see that?
Yes, sir.
And there in the bottom third of the cover page, well, let's just stop. It says, the whole title is What Physicians Need to Know, Healthcare Crisis in Oklahoma. You see that?
Yes.
And there at the bottom it says, Pain Management, How to Avoid the Road to Addiction. Speaker, and you say it, Terrell or Terrell?
Terrell.
Terrell Phillips, DO. That's you, isn't it?
Correct.
And you spoke at this very thing.
Yes, sir.
Okay, and when you did that, you were not getting paid $10,000 flat fee. You were just doing it as a doctor and a member of OSMA, right?
Correct.
Weren't paid at all, were you?
No, sir.
Okay. Your Honor, at this time, we'd like to offer this as States 4742.
I have no objection.
This will be admitted into the evidence and given the number of states 4742.
Now, Dr. Phillips, I know it's been some time. It's been a little over, well, not quite 3 years since that happened. So I've made a transcript of what we pulled off of there. Your Honor, may I approach?
Yes.
All right, I have a video of this I'd like to play. We'll offer it as a court's exhibit. You can look at it. Just want to make sure that what's being said here is heard by the court. Your Honor, may I play this video? We've got to take a couple minutes.
Any objection from the defendants?
I haven't read it, Your Honor. I'll read it right now. I doubt I will.
I'll give you a minute or two to read that.
I don't have any objection.
Thank you, Your Honor.
Permission to publish.
Thank you, sir. We'll play these in two parts. Now, the sound quality was a little low, so we put a I don't know what you call that, subtitle on it. So let's listen to the first clip, sir, and then I have a few questions. Now, before we start, is that you?
It is.
Handsome. Look just like the gentleman sitting there without the glasses. All right, so let's play this one.
Again, I don't want to go across the kind of article, but this is a serious topic. And being heard good is time to talk serious about how we take care of pain medical patients. And the things I say on what I recommend, I issue come out with in my office that I don't prescribe high dose narcotics, and your patients spend a long time that you're not a patient that is appropriate for chronic pain. So, patients are patients for chronic pain.
So let's stop there, sir. That's you talking about how you treat patients, and we heard some of that here in your testimony today, right?
Yes.
But what I heard you say, and I wrote it down, and it's in front of you, it says, this is a serious topic, and since we've got an epidemic, and stop beating around the bush, it's time to talk serious about how we take care of pain medical management patients. You see that?
Yes, sir.
You may have forgotten that that happened back in 2016, huh?
I did.
Okay. So you have referred to this as an epidemic, true?
Obviously, I have.
Okay. Now let's look at the other part.
And again, we all, everyone here knows how we got to this situation. That they know we're going to prescribe. We need to prescribe more patients, right? Have pain medicine, so we all have on board. And there's no one gets hurt. I know that we need to. That's his job. Not everyone deserves pain medicine.
So I'm going to make sure that's clear. I'm going to read it back. This is what was said. Everyone here knows how we got in this situation. They told us we were under prescribing. We need to prescribe more. It's the patient's rights to have pain medicine, so we all got on board. And when someone said they were hurting, we said, okay, we are going to give you something. Now it's just the opposite. Not everyone deserves pain medicine. Did I say that correctly?
You did.
And that was you, the OSMA, CME, talking to fellow doctors and practitioners here in Oklahoma 2.5 years ago. True?
Yes.
And you were not getting paid $10,000 a day to talk back then, were you, sir?
No, sir.
And Janssen and Johnson & Johnson didn't control that presentation, did they, sir?
No, sir.
They never saw it, did they?
I don't know if they did or not.
And you've I don't want to know what you did or didn't do, but you've been preparing with them to come testify, true?
Yes.
Did you tell them about that presentation?
They were aware that I made that presentation.
They were, but it wasn't shown here in court, was it?
No.
So you know, I talked to you about that knot. This is something I learned about that knot. You can really make something look hard and complex, but it takes about 1 second to unravel it, doesn't it?
Yes.
Yeah. Okay. Thank you, Your Honor. I have no further questions. Sir, I appreciate your time. Good luck to you.
Thank you.
Mr. Beckworth, we had showed permission to post the video. We have the transcript. Was the transcript just a court's aid?
I have no objection to both being.
I'd like to offer it into evidence as an actual exhibit as impeachment rebuttal. If we may, the next one would be 4743, and then we would, if you allow, then we'd offer the video as a however we're supposed to do that.
The transcript of the video will be States 4743. I'd like for the state to provide a copy of the video on a thumb drive, and we'll reserve that as States 4744.
Thank you, sir. And we'll bring any of that up as soon as the witness is excused and give us a break. Thank you.
Mr. Otterly?
Just a few, Your Honor. Dr. Phillips
Did the fact that you charged me have anything to do with your testimony here today?
Not at all. I had a specific reason. I felt it was very important that the court hear from someone that represents Oklahomans, that's been here for 30 years treating Oklahomans, and someone represent the tens of thousands of patients in Oklahoma that suffer from chronic pain, and that is a serious problem that cannot be overlooked and that we have to take seriously. So I felt that voice needed to be heard.
Right, and they took some statements out of the presentation you made. You still stand by that presentation?
Yes.
All right. And doctor, I want to ask you just one last time. Did anyone from Janssen ever tell you that opioids were more beneficial or less dangerous than you have found to be true in your own experience and practice?
That has never been the case in my practice.
That's all I've got.
Nothing further, Your Honor.
Thank you. Dr. Phillips, thank you.
Thank you.
You may be excused.
Yeah, go back to the simple line.
Mr. Ottaway.
Your Honor, I'm pleased to announce that the defense may call its last witness a 12-minute video of Ms. Katie Chupa.
All right. Let's go ahead and show the video of Ms. Chupa.
Can you please state your full name for the record?
Kathleen Chuba.
And Ms. Chupa, what do you currently do for a living?
I'm retired, and I'm retired.
Good for you. Prior to your retirement, what did you do for a living?
I worked for Janssen Pharmaceutica.
All right, and after your Director of Business Development role, what was next?
I went into a marketing role,
What was the title of that position?
product director, Duragesic.
Okay. And what were your responsibilities as the product director during GZ?
Multiple responsibilities as part of a brand team. We rotated responsibilities, so it was anything you would do as a product director.
It was, you I think said earlier, it was a marketing role.
It was a marketing role, yes.
So can you just list, you said you rotated responsibilities. Can you list some of the responsibilities that were rotated?
Sure. You might work on a brand plan, like a business plan. Work with, be a liaison to the sales force would be another activity. Maybe be a liaison with market research. Finance. Those would be typical responsibilities.
The next bullet point says Janssen was initially reluctant to enter non-malignant pain, right?
That's what the bullet point says.
Do you disagree with that?
No, I don't disagree with that. We had multiple priorities, so yes, it was a difficult decision.
And why was it a difficult decision?
We just had other drugs that we were trying to balance in the meantime, so.
You would agree, though, prior to the expansion of opioids being used in non-malignant chronic pain, it was rare for opioids to be used in non-malignant chronic pain treatment, correct?
Yes, say the question again.
Yeah, sure. Prior to by necessity, prior to the creation of a market for the use of opioids in the treatment of non-malignant chronic pain, before that, it was rare for opioids to be used in the treatment of non-malignant chronic pain.
Well, the way you phrase your question, that would be true. I object to the word created the market for chronic pain, I guess, so.
You would agree with me, though, that prior to the 1990s, there was not a market for the use of opioids in the treatment of non-malignant chronic pain.
I would say that the market began to be realized with the undertreatment of pain for non-chronic pain conditions in the 90s, yes.
And Janssen was initially reluctant to enter that non-malignant pain market, correct?
Yes, I mean, I think we were thinking, yes.
The next bullet point says Duragesic sales for CBP, that's chronic back pain, right?
That's correct, yeah.
Growing at 35% annually, worth $130 million, or 20% of total sales,
Mm-hmm.
right? Is that right?
Yeah, that's what that says, yes.
And so this indicates that after Janssen overcame its initial reluctance, Duragesic was being marketed for chronic back pain, right? And being prescribed for chronic back pain.
Yes, it was being prescribed for chronic back pain.
And marketed for chronic back pain.
I'm just looking at it, I'm trying to align the dates. It looks like this is sales volume 1996 and 2001. So that's possible at the end of that period that we were marketing for chronic back pain, yes.
And I mean, you agree that during your tenure at Janssen, Duragesic was marketed for chronic back pain?
Oh, yes, it was marketed for chronic pain.
When you first started working with Duragesic in 2000, what was the market focus for the product at that time?
The market focus in 2000 for Duragesic was just moving from oncology into the chronic non-cancer pain space due to the availability of more sales resources so we could form a sales team for Duragesic.
And why did the company then shift its market focus as you just described?
We shifted the market focus, again, because of the undertreatment of pain and the unmet medical needs for some of our patients. We saw that in chronic low back pain and osteoarthritis, chronic osteoarthritis, there were patients that needed some different therapies, some alternative therapies to what was on the market, and we went into those areas.
How did you know that there was an unmet need, as you just described, in that area?
We did multiple market research studies to help determine that, and talk to physicians, and we also talked to patients. We had patients that were writing us letters. We had patients that wanted to come talk to us and tell us their stories. So we had market research sessions at a facility with a facilitated market researcher leading the conversation, and patients would come in and they would be able to tell their stories.
Okay, so these are specific sessions. Can you describe to me what you're talking about, how it is that you would hear directly from patients?
Yes, the patients were invited to a market research facility. The people that invited them were a market research company. It was blinded to who the company was that was interviewing them. They knew that there were people behind a glass wall that were listening to the conversation. It was told to them that they were a pharmaceutical company. It was said that there were some people from marketing, some people from market research, and some people from medical affairs listening to the conversation. And then the market research facilitator would ask the patients questions about how they were feeling, what medications they were on, how it had made a difference in their lives, where they still feel that they needed help, what they were looking forward to, and they left unopened questions at the end about what they just wanted to tell us about their situation.
How often would you hold these types of sessions?
Remembering back to Duragesic, I know we held 2 sessions, about 6 months apart. And for Nucynta ER, we did do 1 session, I remember that.
And who would attend from the company's side? I believe you just described a few, but overall, kind of what type of folks from Janssen would attend these presentations?
The Janssen people that would attend would be marketing team, some people in the marketing team, market research, medical affairs, That's primarily who was there.
And what did you learn from the sessions where you were able to hear stories from patients directly?
It was very emotional. People came in wheelchairs, people came on a gurney, some people could walk, but they all had their own story, it was all unique. And they described very different patient journeys of how they had gotten to the place they were in. And some patients described how pharmaceutical products had helped them. Some people described how they haven't gotten relief from pharmaceutical products. A lot of people talked about interventional therapies. And there was a lot of interest in wanting to make sure that pharmaceutical companies were committed to the future of pain. They wanted to make sure that what is new, what is coming out, what are you working on? Questions like that were asked.
And what specifically did some of the patients say they wanted from medications?
They wanted to be able to do things that you and I take for granted every day. It's really about activities of daily living, improvements in their functioning. One person was a grandmother and wanted to go to one of her grandson's baseball games. And she said she couldn't walk to the bleachers or sit there for as long as he would play. And she said, I don't care if I go for 2 innings, I just want to go. And it was just a very emotional experience. And you could see the amount of just immense pain that they had had all their lives.
So what was the impact on you personally in attending these sessions?
Very emotional. My team was very emotional, and it also made us very committed to making sure we were focused on how to bring these solutions to patients. And I think it was good for the teams to be there. I think the market research team was really blown away from seeing patients that up close and personal. You get a very different feeling than when you're interviewing people on the telephone or you're doing an internet study. You just don't get that emotion and you don't get the personalization. Our medical affairs people had ideas for new studies, outcomes, and patient-reported outcome studies, and how they were going to do new studies to determine if our products were actually helping in the way these patients wanted. So I think it was a lot of new ideas were generated.
And so you talked about how what the medical affairs folks did was some of what they learned at these sessions. Can you identify any other way in which the company utilized information that it learned at the sessions in its business?
At the time, Janssen's always been patient-focused, but I would say there was a real uptick in thinking about the patient in all different therapeutic areas. When you come into any of our facilities in Titusville or Raritan, you see patient stories on banners, you see patient quotes. We have art that has been done by patients, by schizophrenic patients, by patients in pain that were on the back of all of our business cards. Like I had pain patient art on the back of my business card. If you were in a antipsychotic marketing role, you would have those patients' art on the back of your business card. And it just wanted to make it personal and wanted to make the CMO's quote of our patients are waiting real and wanted to make it live. I know they're doing a lot more now. And obviously I haven't been there for 5 years. But I was just in Titusville a few weeks ago, and there's more and more patient stuff everywhere. So I'm glad to see we're still so strongly committed to the patient.
And you said that a few folks from marketing would attend these sessions. Would you do anything to try and convey what you learned to other folks in marketing or sales at the company?
Oh yes, every Monday we had a big team meeting, and our teams not only were the marketing team, but it was our partners that were in finance, our partners that were in market research, our partners all over, and there's probably 25, 30 people there, and we had a whole presentation doing the best job we could for the people that were physically at the facility to share what it meant to us, and to share the verbatims.
When you said the verbatims, what do you...
The verbatims are what the patients actually said in their own words. We told them how we felt, and then we said, this is what the patient said.
That concludes the deposition, Your Honor. I believe we, with the permission of the court, if we will need to make a motion motion ready to rest, Mr. Brody?
Yeah.
And we can make that later if the court wants. I think the plaintiff has a rebuttal video they want to show.
I think we'll recognize Mr. Brody first.
All right. I'm just trying to rush through so we can get out before lunch, as I promised.
Thank you, Mr. Brody.
I think we'll get out for lunch. I can be about 90 seconds on this, Your Honor. We are moving for judgment on all of the evidence after presentation of the evidence in our case in chief. We have prepared a reasonably short brief that addresses the additional reasons why we believe the court should grant the motion, building upon the evidence that has been presented during our case in chief. The grounds for that are fully stated in the brief that we will be filing. I believe it's probably being filed right now as I'm speaking on this motion. Very briefly, the grounds are that the evidence is insufficient to prove a public nuisance, that the state's claim is barred by the First Amendment, that both federal law and state law bar liability for Noramco and Tasmanian Alkaloids' sale of active pharmaceutical ingredient, that the state's claim is preempted by federal law, that the evidence is not sufficient to show that the defendants were the cause of the opioid crisis in Oklahoma, that the state's own role entitles defendants to judgment, that the evidence shows that defendants cannot be liable for the entire Oklahoma opioid crisis because the state did not prove an indivisible injury and because imposing joint and several liability would violate due process. And finally, that the state's abatement remedy is not available here, is unsupported by the evidence, is barred by the Oklahoma Constitution, and violates both the due process and excessive fines clauses of the U.S. Constitution. And all those reasons and the grounds therefore are fully set out in the brief that is being filed with the court. We will understand if the court wishes to take that under advisement, but request that if the court does so, that the court does so without waiver of any rights and any of the arguments that we are presenting in this motion. Thank you.
Thank you, Mr. Brody.
There will be no ice cream cones. Your Honor, just real briefly, we have no issue if the court takes that under advisement and won't claim a waiver on behalf of Janssen or Johnson & Johnson. Unless the court so orders, we would be disinclined to file a brief and just head to closing arguments, assuming Your Honor allows us to get that far. Brief response, we had this argument just a couple of days ago or 4 days ago. I think that since that happened, the witnesses the defendants have called have continued to unravel. I think many of their witnesses have been much stronger for us than for them, including Dr. Murray, who testified, among other things, that when he listed all the potential causes of the opioid crisis, it was pretty strong for us. And then the gentleman that just testified, I think the video clip I showed the court says it all. So we would ask that any such motion be denied. And then, I don't know if you want to stop for a second or not, but I can give the court a little insight on what we're going to do the rest of the time.
Yeah, let me go ahead and what I'm going to do is I will take the motion for judgment by Mr. Brody under advisement until I've read the brief, but also consider it together with all the other evidence that has been presented thus far in the trial. And I'll recognize that that will not act as any type of a waiver of rights of Johnson & Johnson or Janssen.
Thank you, Your Honor.
Thank you.
So, Your Honor, just a couple of housekeeping matters for the state. We do have one video rebuttal witness, Matthew Martin. I think it's about 7 minutes. With the court's permission, I would ask that we maybe do the following. I think we could show that now. We are considering calling Commissioner White briefly. It would help us if we had lunch to make a final decision on that so we don't waste anyone's time. And if we show this video now, it might give us 25, 30 minutes if Your Honor had indicated you wanted to take up a few pending motions. I'm not even sure what they are, but I'm ready to argue them anyway. So I don't know if you want to do that first and then the video, or video and...
Let's go ahead and, assuming there's no objections that are sustained by me as far as showing the rebuttal video, then we will take up those motions and break for lunch.
Perfect. Okay, thank you. All right, we'll play that one now.
Can you please state your name for the record? Matthew Martin. Okay, fair enough. Are you retired? Yes, I am. What did you do before you retired? I worked with Aramco. How long did you work with Aramco? From 2002, I think, till June of 2016. All right, so for 14 years? Yes. And where were you based when you were working for Aramco? Some of the time I was based in Wilmington, Delaware, and some of the remainder of the time I was at Janssen and Fentanyl. At Janssen. So it's fair to say that Aramco was part of the Johnson & Johnson family of companies? Yeah, the folks from Aramco were from Johnson & Johnson. Okay, thank you. And then at some point in time, in 2016, Aramco was sold, right? That's correct. To a private equity firm, correct? Correct. SK Capital? Yes. Does SK Capital still own Aramco? Yes. All right. And why exactly did you leave Aramco? To retire or no reason? I left Aramco in 2017, I think, January 2017, I left Aramco to retire. My plan had always been to retire as quickly as I possibly could. Are you familiar with Tasmanian Alphabets? Yes, I am familiar with that. And that's another company that is in the Johnson & Johnson family companies, correct? Yes, that's correct. Is it fair to say that Aramco and Tasmanian Alphabets were sister companies? They were sister companies in the sense that both of them were part of Johnson & Johnson. How did Aramco relate to the Treasury Department of Johnson & Johnson? Was that where the money for Aramco flowed through? I don't know where it flowed through, to be honest with you. But Aramco didn't maintain its own separate accounts? I don't believe it did. While Aramco was a Johnson & Johnson company, it was held to the Johnson & Johnson credo, right? The credo was certainly traveling throughout the different companies, yes. And Aramco was supposed to abide by that credo, while it was a Johnson & Johnson company, right? Yeah, it is a credo. It's a way of doing business. That's correct. And it applies to Aramco. It applies to Aramco. And in fact, Aramco posted the credo to its website. Sure. I did not know that. And you exhibit 3. This I pulled from the Aramco website that existed around 2005 or 6. As you can see at the bottom, where there's a URL, you'll see that it comes from aramco.com/credo. I see that. And this is the Johnson & Johnson credo, correct? See that at the top left? I do see that. And were you familiar with this credo while you worked at Aramco? I was familiar with the credo. I did not receive any training on it. I don't think individuals receive training on this. The first line of the credo states, "We believe our first responsibility is to the doctors, nurses, and patients, to mothers and fathers, and to all others who use our products and services." Did I read that right? You read it perfectly. First responsibility. Is that what it says? That's what it says. Above all others. Right? Our first responsibility is to the doctors, nurses, and patients, to mothers, fathers, and all others. Yes, that's correct. And that first responsibility applies to the Aramco law with the Johnson & Johnson company, right? It was available to individuals within the company, yes. It applied to individuals at Aramco. It was certainly a guideline. You mentioned earlier that you were aware that Purdue pled guilty to federal felonies for misbranding OxyContin in 2007. I have that. OxyContin is an end product that is prescribed to patients here in the United States, right?
I think patients who are given a prescription and use it, that they would be, that's what my knowledge is.
And Aramco has supplied oxycodone API to Purdue, which goes into OxyContin, right?
Yeah, Aramco does or did supply to Purdue.
So you just kept providing oxycodone to Purdue, didn't you?
We continued to provide the product to Purdue that both the FDA and the DEA allowed them to take from us.
FDA didn't require you to provide supply to Purdue, did they?
At the end of the day, Aramco was in this to be able to make some money, some profit. And I think in that time, Purdue was a fairly good customer, and we continued to supply as they were still a company that was in good standing with the DEA and the FDA.
And your concern at this point in time was supplying product to customers. Your primary focus was not on patients or physicians. Is that true?
I think one thing that I would say is that Aramco is primarily and only a business-to-business operation, and that's where our sales go. We do not interface with any of the customers or distributors or anyone that supplies product to consumers.
Since your focus was not on patients whenever you were at Aramco, you never looked into whether or not people were addicted to the products you were making.
That's a true statement.
And does Aramco have any role in evaluating the risks and benefits of the pharmaceutical products that its customers manufacture, or did Aramco rely on its customers and regulators to do that evaluation?
Aramco relied on their...
I can't hear it.
To do the investigation of the risks and benefits of the pharmaceutical products? And Aramco didn't do its own independent evaluation of the risks, did it?
Not my knowledge. Did Aramco understand the risks associated with the APIs in manufacturing? In what context? Any context. You testified in... No, I would say no. Aramco wasn't aware of all of this.
Thank you. If you'll just provide a transcript for me, that will be helpful. I've heard 99% of it, but there was a few answers that were tough to hear.
Okay, we'll get that to you, Your Honor. And so that is, with the exception of maybe the one live witness, that's it from us for now. So I don't know if you want to take a
we are going to take a break for lunch. I know there was probably some hope that we wouldn't, but we will. So I would like to use our remaining time to take up any outstanding motions that I have not ruled on.
There's two that I'm aware of. One was when they filed to exclude all of Dr. Polani's testimony, and then one dealt with some affidavit or something from a guy in Mexico about the Growing Pains website. Those were the only two. We didn't respond in writing to both of them, did we? Yeah, I wouldn't know. It's been a long time. Were there any others?
Your Honor, those are the only two that we have on our list. We are happy to have the court decide those on papers that have been submitted. The state has responded to both of those. And so at this point, if they have no objection, we'd be happy to have the court just decide those on briefs.
We will do that. I will do that. Very good.
I believe we would have an objection to any additional rebuttal case. It would meet the standards that are applicable of things that are not anticipated or couldn't have been presented in the state's case in chief. But again,
Mr. Beckworth, can you tell the court who you intend to call and for what purpose?
We would call Commissioner White just for a few brief rebuttal points from some of the testimony we've heard in the last couple of days. And what I would request, maybe if we, I don't know what the court schedule is, but if we could resume at 1 instead of 1:30 if we broke now, and then we'll be able to let the court know whether we're going to do it or not. Or earlier than that, whatever your honor would like.
What we'll do is we will resume at 1 o'clock, and Mr. Brody, you can renew any objection you have at that time. All right? Thank you.
Thank you.
I'd like counsel to come on up.